Please welcome our special guest on the show, Dr. Abu-Sittar. He's a consultant hematologist and hemato-oncology. Abid, thank you very much for being in our show.
Thank you.
How are you doing today?
Thank you very much.
Okay, let's talk about you.
I'm a consultant hematologist and hemato-oncologist. As you said, I have been in this field as a consultant for the last 10 years, spent 5 years in training before that. And I currently work in Essex.
Excellent. Right. You speak Arabic.
Yeah.
Where does your family come from originally, do you?
Well, I'm originally Palestinian.
Palestinian, all right.
I was born
because I never had anybody from Palestine. It's
No,
very
I'm not
interesting for our
surprised.
viewers
Sure.
to
Yes.
see someone from Palestine and
Yes.
here.
Yes, probably not too much Palestinians in hematology either, so that makes it
Exactly, yeah.
rarer, yes.
So you're
Agree.
from Palestine, right? Okay. Where did you study? Did you study in Palestine or did you?
Well, I did my postgraduate training in the United Kingdom, but I did my primary medical degree in Tripoli in Libya.
In Libya.
Yes.
Do they have medical schools in Palestine at the moment, or is it?
Yes, yeah, they have medical schools in the West Bank.
All right.
I think at least there are 3 medical schools, and there is a medical school in Gaza Strip as well.
So there are 4 medical schools still.
Yes.
They are all
Yes.
running normally. Why did you choose hematology? What was the interest behind it?
Well, that's very interesting question, in fact. Since I was in medical school, I found the hematology topics are more interesting. And hematology in this country combines clinical and laboratory work. And so it provides an opportunity for variety in the work experience. And then when I did my training as a junior doctor in this country, I was exposed to more hematology, and I decided by the time that was going to be my long-term career.
That's actually it's a very good subject, and a lot of people are interested, especially when you say about blood cancer. People think, wow, this is a killer, that I'm going to die. But it's not anymore, isn't it? It's a lot. We're going to talk more in detail. What is leukemia or blood cancer?
Well, leukemia is a term which came to existence from the early 50s, and leukemia in simple terms means white color, and this is because of it's a disease or malignant disease of the white blood cells, it is a very heterogeneous.
Let's clarify a bit here before we go ahead, because there'll be children watching our programs as well. Okay, let's say what kind of blood cells are around in our body.
Okay, so simply thinking about blood, there are 3 types of blood cells.
I'm going to hold you there. There's a caller coming straight away in Towland. Hello?
Hi, can I ask one question, please?
Definitely. What's your name, please? Where are you calling from?
I'm not telling my name.
That's fine. You could say where you're calling from at least.
Sorry?
Where are you calling from? What part of England or?
Yes, England.
Oh,
Yeah.
okay. Good. Thank you. Yeah, go ahead with your question. Thank you.
Yeah, thank you so much, first of all, you both of them, because it's really important. And I have got, when my elder, the daughter is born, 2005, then I've got the hernia, Then I think, I'm not sure, after that, I've got operation. Now, then my hernia is come back again. I'm feeling my belly button here is a little bit lump, slightly bigger, like egg size. Then I'm feeling pain again. Then I'll see the doctor. I'll call the surgery. They said, can you come? Then I'll book an appointment for you if we think you need it. Then they will refer hospital. Then I'm going here. Then they will do the ultrasonograph. And they said, you need another operation. So my question is, do you think when I leave my phone, you give my answer, do I need hernia operation again, or can I avoid the hernia operations? And is any activity, if I do that, can I do this one without operation?
Thank you very much. It's a very
Thank you so
interesting
much.
question. Yeah, it's a very interesting question, sister. Have you heard the question?
Well, I haven't heard the whole story, but she's going to have a hernia operation.
Yeah, exactly. So this lady had a delivery 2005, I think, she had a baby. And since then, she's having a hernia, and she had an operation once, but the lump is coming back. It's somewhere around the belly button, and now she has gone to the GP, it looked like, and the GP said she might need another surgery, and she's still got pain around there, and actually she is asking what to do. Can she go for another operation? Look like you have a hernia, so there is two ways. If they have done an ultrasound, as you said, the ultrasound will generally say the major problem with hernia. Generally, it is fine if a hernia is there, but sometimes it can get obstructed, or internal organs can pass through that hernia sac and they can get obstructed. That's the time it becomes an emergency. You need an operation. But sometimes if they feel like it is going to go that way, and your doctors might advise you at that point, okay, go ahead and operate and fix it. Once it fixed, it should not come back. But again, it comes back. They call it recurrent hernias. If it comes back and you go back again, they put a plastic sheet on top of that hernia area and they suture it, and usually it stops. In most people, in 90%, it stops there and they don't come back. But anyway, there is a good video on Health Talk with Dr. Akram YouTube channel about hernia, and please go and watch there and write something there, and we will come back to it in more detail. Thank you very much for your call. Okay, let's talk quickly a little bit about leukemia.
The white blood cells are the cells in our blood which have mainly one function, is to fight infection.
White blood cells.
Yes, and then we have the red blood cells.
Red blood cells, yeah.
Which carries the oxygen to our various organs.
Yeah,
and we have the
body,
platelets, or simply called the clotting cells, which stops us from bleeding.
Those are three major
cells. Yes.
And leukemia,
leukemia, where if there is cancerous proliferation of the white blood cells, while the excess of the red blood cells, we call it polycythemia. Deficiency of red blood cells, we call it anemia. And the platelets, if they are low, we call them thrombocytopenia, while if they are high, we call it thrombocytosis. And important people, they don't mix between thrombocytosis and thrombosis.
So when people say blood cancer,
yes,
what do they generally mean?
Well, blood cancer is rare disorders. They are malignant tumors of the blood where there is proliferation of the certain lineage of the blood cells. It could be usually the white blood cells, very rarely red blood cells and
generally
platelets.
It's white blood cells.
It's when we talk about blood cancer in hematology, we generally mean leukemia. However, there are other blood cancers which the name is completely different from leukemia, like myeloma and lymphoma. Lymphoma is cancer of the lymph glands, while myeloma and leukemia both are blood cancers.
Okay, how common are leukemias?
Leukemias.
These are white blood cell cancer, which actually this is very common, isn't it?
Yes. So the leukemias, there are two main types of leukemias. Generally speaking, acute leukemias, which usually comes over a matter of weeks, and
a matter of weeks,
probably months, and they are usually proliferate quickly, and treatment should be given sooner rather than later. And there are chronic leukemias. And if you want to talk about the leukemias, the acute and the chronic, there are subtypes which like lymphoid leukemias and myeloid leukemias. And there are certain leukemias which are commoner in children than adults. And the other ways. But generally speaking, blood cancer leukemias in particular are they are commoner in elder patients.
Elderly patients, right. Okay. Okay, we'll talk more about leukemia and anemia and everything. So anyway, if anyone joined the program today, we are talking to a hematologist here, and we'll talk more after a short break. Hi, welcome back to Iron Health Talk with Dr. Akram. In this program today, we're talking to a hematology consultant. His name is Dr. Abid Abu-Sittar, and our main point is talk about leukemia. Let's talk about leukemia now, and after break we'll talk more about anemia and deep vein thrombosis. Let's go back to leukemia. Okay, risk factors and who gets it?
Right, okay. I think the most independent risk factor for leukemia is unfortunately is age. So
age. Okay.
So of course there are certain leukemias.
What kind of age they get leukemia?
Well, it is when we talk about age, we talk about the age of greater than 65.
Greater than 65.
And we talk about acute myeloid leukemia.
Acute myeloid leukemia, a kind of,
which is about 80% or more of the acute leukemias. As we talked earlier, there are
80% of them are
two main types of acute leukemia: acute myeloid and acute lymphoid. The acute
myeloid is 80%, the other one is 20%.
20%. Yes, and if we talk about the acute myeloid, because that's the commoner leukemia, it is
that comes for elderly people, as you said.
Yes. Well, the incidence in people who are less than the age of 65 is about 1 to 2 per 100,000, and the risk goes up to 10% to 20. 10 to 20 per 100,000 population. So it almost goes 10 times, but on overall it's still a rare disease. So if we talk about the incidence in people who are over the age of 65, the incidence is about 10 cases per 100,000.
So 10 cases per 100,000 people. So it's not very common.
It's not very common. It's not as common as the cancer prostate or cancer.
What causes this leukemia?
Well, there's, majority of cases, there are no predisposing factors. It happens due to random
So it's
mutation.
not like you eat funny stuff, you smoke on this.
No. Well, there are some thoughts that smoking increases the risk of acute leukemia, but what we know for certain that the risk is increased by exposure to certain chemicals, including previous chemotherapy for other cancers, and radiation as well. But in majority of cases, there is no obvious cause. It's due to random mutations happens in the stem cells.
And what kind of symptoms?
Okay, the symptoms again, they vary a lot because the leukemia can cause shortage in the 3 types of cells we talked earlier. So it kind of or it causes the combination of symptoms. So because it causes anemia. And
so leukemia causes anemia?
Of course, yes. Yes, and that can be presenting
red blood cells,
feature or symptom. It can cause infection. So patients, they can present with infections.
Yeah, that's right, isn't it? Because white blood cells, which are the cells which protect, but if they're cancerous, they can't protect the body. Yes,
absolutely. And then it can present with low symptoms, platelets, so clotting, bruising or bleeding symptoms. In general, patients, they present with tiredness and fatigue.
Tiredness and fatigue.
Tiredness and fatigue and pallor.
Yeah, pale.
They
Yeah,
will
pale
notice,
white,
or
yeah.
somebody else, a friend or a family member, will notice that they become pale, and then they have a blood test. In extreme rare scenarios, but I come across this probably once a year, where people do have a routine blood test, and we are still
Routine
talking.
blood tests, yeah.
We are still talking about acute leukemias,
Yeah.
while chronic leukemias, they may not cause any symptoms at all.
So chronic leukemia can be with you for a long time.
Yes, yes. The chronic leukemias, they again, there are subtypes, but the commonest type, which we call CLL, not usually presents with no symptoms, and routine blood tests done, which will pick up high white blood cell count,
Right.
and then further analysis will confirm they have
So this is picked up randomly when you do a test or something, they pick up
Yes,
and you
yes.
start treating. Okay,
Yes.
let's talk a little bit about the leukemia the children has. Is it a different one?
Yes, if we go back to what we said at the start, there are two types of acute leukemias.
Yeah.
There's the acute myeloid leukemia, which is typically in elderly patients, and there's the acute lymphoid leukemia, which is relatively more common in children.
Children, yeah.
And this is usually, or more than 90% of cases, are curable diseases. And
They are curable, yeah.
yes,
Okay.
yes, yes.
It's not like 10, 20 years ago what we thought.
Absolutely,
Like they all die
yes.
of blood
You are
cancer. No.
absolutely
It's
right.
not like in the films, isn't it?
No, it's it's
Yeah.
it is a life-threatening disease, and it needs to be treated. There is no 100% cure.
Okay, for
But-
children,
Yeah.
what kind of symptoms they get? Like their parents, what do they have to be aware of?
Well, they can present with, again, lethargy and lacking
Tiredness, yeah.
tiredness. They can present with bruises,
Bruising.
or they can present with lumps.
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 Where do they see these lumps?
Well, usually in the neck.
In the neck, yeah.
In the
Small
neck.
lumps.
Yes, yeah. Well, I wouldn't say
grape
small
size?
lumps. Because the children, they get exposed to viral illnesses.
Yeah.
So it's much commoner to find a child with a lump due to viral illness
viral infection.
than due to leukemia. Leukemia is still pretty rare, even in the acute lymphoid leukemia in younger children.
So if the lump persists long time, and probably something to worry and something to show the GP.
Yes, absolutely.
Now you said there are treatment for leukemia. Not everyone dies of cancer, blood cancer now. What kind of treatments we have?
Well, again, this depends on the type of leukemia.
Yeah.
It's very specific to the type of leukemias. Acute leukemias, the acute myeloid and in fact the lymphoid, are treated with chemotherapy agents, and sometimes patients need to have stem cell transplant. But that depends on certain factors at diagnosis, which determines how aggressive the leukemia and what's the risk associated with the leukemias. But many leukemias, they are treated with chemotherapy. Chemotherapy without transplant.
Yeah.
And some patients, they need chemotherapy and they go into a transplant. There are many factors.
When you say transplant, what kind of transplant?
There are two types of transplant. Usually in leukemia, they do allogenic stem cell transplant,
So
which
stem
means
cells.
stem cell
Where
transplant.
do they take the stem cells from?
Stem cells are, over the last 20 years, now they are collected from the veins. It's like not quite similar to blood donation, but it is a big cannula in the arm.
In the arm,
It goes into a machine, and the machine will separate the stem cells from the donor and return.
The stem cells are quite young cells, aren't
Yes, the stem cells are the precursors, or they are the earlier white blood cells, which have the characteristic to differentiate and to adapt to the environment and to change the whole immune system of the recipient.
Right. So do they take it from the patient, or do they from somebody else?
No. In certain conditions, like myeloma, which we talked earlier, it's type
So you will
of,
find a donor, probably.
Yeah, no. In the myeloma, we do autologous stem cell.
So take
So it's from the
them
patient.
and you clean them.
Yes, you clear the myeloma and then you collect stem cells and you put the stem cells back into the patient. While the allogenic bone marrow transplant, which is usually done in cases of high-risk leukemias,
High-risk leukemias,
are collected from donors, and the typical donor is identical sibling.
So if they have a twin brother, twin sister, that's best one, or sisters, family?
Not necessarily to be twin brother or sister. It is identical sibling.
Siblings, right?
Sibling, and in fact, having the stem cell from
brother
a sibling,
or sister,
which is not an identical twin, is better because will have an effect called graft versus leukemia effect.
Do the donors, do they have to be a same blood group, or they can be a different blood group?
No, they don't have to be the same blood group.
You just need a brother or sister who is happy to give you some blood.
HLA matched.
Yeah.
So at the level of the HLA, which is certain
HLA types, there is another type.
Tissue type.
Tissue types,
expressed on the stem cells, and it is very extended work to see the matching in the protein expressed in the cells.
Okay. Let's summarize. So you can we give tablets?
Again, it depends on the type of leukemia.
Okay.
So chronic lymphocytic leukemia, you can give tablets.
You can give tablets.
But again, depending on the certain results in the at diagnosis.
Okay.
The alternative is intravenous. There is a lot of treatment now these days is under the skin, but
that's chemotherapy.
Chemotherapy. Yeah. But we are moving away from traditional chemotherapy, and we're using more biological treatment.
These are the new ones.
Yes.
Exactly.
Yes.
What are the new medications these days? What is like general? How can you explain our viewers?
Well, I will take an example of a condition, chronic leukemia, called chronic lymphocytic leukemia, which is, again, a lot of patients, they don't need treatment and they may enjoy the rest of their life without need of treatment. But in the past, we used to use treatment which makes people sick, lose their hair, admitted to hospitals. But now we're using biological treatment like a drug called ibrutinib, which is, we call it this, the scientific name is BTK inhibitors. And the other example, which is chronic myeloid leukemia, we use Glyvic or imatinib, which it's a biological treatment.
It's again a biological treatment.
It's biological treatment, and it reverses the main abnormality in the abnormal chromosomes causing.
So you target the chromosome and change. What's the name of that medicine?
Glyvic or imatinib. Yes, there's a lot of them at the moment. And the first one, which came to practice about 20 years ago, called.
Right. And how do you take that? Is it like intravenous?
Just a tablet.
Tablet.
Just a tablet.
And this tablet goes to your chromosome and changes?
Yes, it just basically stops the enzyme which binds two chromosomes together, makes them very sensitive, and it breaks that bond between two chromosomes, chromosome 9 and chromosome 22. And it breaks that bond, and the breakage of this bond makes the proliferation of the white blood cells.
That's amazing. These new treatments are amazing. We're going to talk a bit more about it, and let's again, it's time for a short break. If anyone joined the program today, we're talking to a hematologist here, and we have so far covered leukemia a bit, and we have reached to the treatment, and we'll talk a little bit more about anemia and deep vein thrombosis in the next part of the show. So see you after break. welcome back to Iron Health Talk with Dr. Akram. In this program today, we're talking about talking to a hematologist. So we're talking about leukemia, anemia, and TB. So far, we have covered leukemia, and let's go and talk more about anemia and deep vein thrombosis. This is really important. Okay, let's go back. What is anemia?
Okay, thanks.
We have covered it.
Akram. Yes, I think now, if you remember, we talked about the leukemia earlier, and we talked about a rare disease, which is in those who are less than the age of 65. It's about 1 to 2 per 100,000. But when we talk about anemia, it's very common.
It's a big subject.
Yes. I mean, specifically, the anemia is commonly due to iron deficiency. And
Iron deficient anemia.
yes,
yeah.
and that is the incidence is about 1 in 5 of women.
1 in 5 of women
of reproductive age, they get
during the
iron
pregnancy,
deficiency,
during the
mainly because of monthly blood loss during period. So this is a much commoner area of hematology, and identifying anemia is
actually anemia. We should have a full program on it. But
yes, absolutely.
Let's give them points.
Yes, absolutely. Yes. So it is. It depends on the type. Again, as you rightly said, it's a wide variety of.
Okay, let's talk about anemia.
Yes. So anemia is again. Anemia is a sign of an illness, but is not an illness, if you know what I mean. So there is the commonest is anemia due to iron deficiency.
Iron deficiency, that's during the menstrual period.
Yes, and there is anemia related to vitamins deficiency,
Vitamin
like
deficiency,
B12 and folic acid, and this is not rare.
That used to be called for vegetarians. They used to have.
Yes,
that.
I mean it depends on the type. It can be seen in vegetarians who don't eat meat at all, and it can be seen in people with malabsorption, like celiac disease, and it can be seen. Yes, but in alcoholics, it just indirectly related to nutrition because they don't. Eat balanced diet. And there is finally the pernicious anemia, which is an autoimmune problem. They don't absorb B12 because of autoantibody interfering with the absorption mechanism. And of course there are other types of anemia like thalassemias, which is due to hereditary problems,
anemias,
and there are anemias due to, or we call them autoimmune hemolytic anemias, where the body starts to destroy the red blood cells, and anemia can be caused by chronic illnesses as well, and the best example for that is anemia in people with chronic kidney disease.
Signs and symptoms.
Yes, signs of symptoms of leukemia is mainly lethargy and lacking energy. If it's severe enough, it can cause, especially iron deficiency, it can cause hair loss.
Hair loss?
Yes, it can also cause palpitations.
Oh, palpitations.
Yes, these are the symptoms related to shortage of oxygen delivered.
Because your body is starved for oxygen, and it asks the heart to pump it. Heart
more.
cannot pump.
Yes.
And it tries to pump faster.
Yes, and in fact can lead to shortness of breath.
Shortness of breath. And again,
that's again because of the lack of oxygen into the muscles and other organs.
Okay. If anyone has these symptoms, what is the next stop for them?
Well, if anyone, generally speaking, especially in this country, most people who goes to the GP for any reason, they will get GP, blood count. And the blood count almost always shows anemia. However, it's important to point out that sometimes people, they are short of iron and they are still at early stage and they are not anemic and they will still get symptoms of anemia. So they will have normal hemoglobin, normal blood count. If you look at their blood count, it doesn't show anemia, but if you check the iron level, and if they lift, only if they are left and treated, they will become anemic after months or possibly years.
When the iron deficiency start, they will start feeling the symptoms.
Well, not when they start. As soon as they start, it takes some time because our body has the reserve, and the resilience. So the deficiency can be compensated, but at some stage it will be.
Okay, that's the point you worry about. You go to the GP. Okay, and management. Yes, first of all, you need to identify the cause of iron deficiency. We are talking about iron deficiency anemia. And in a woman of reproductive age, if there is a good history of severe blood loss during the periods, you have to give iron replacement, and the patient should talk to the GP. Exactly. That could be given as a tablet.
Yes,
generally.
as a tablet. And usually the tablets is better to be taken away from food, preferably with orange juice, because vitamin C enhances the iron absorption.
So you don't take it with food because, again, food
it can cause side effects, and it may be poorly absorbed. And it won't be, because we naturally don't absorb iron very well.
Oh, okay. That's
so
very interesting.
If we eat about 15 grams of iron, we absorb 1 to 3 grams of iron.
Right. That's interesting.
So that's why it's better to take it. And sometimes people, they take the iron tablets and they don't absorb it very well when we have to give intravenous iron. But that's
very rare,
common, yes.
Okay, we we talked about the treatment here as well. Treatment it depends on the problem, isn't it?
Yes. So we talked earlier about the iron deficiency anemia, while the B12.
B12 deficiency, you give B12?
B12 is, we ask about the diet, and of course we have to replace it. And the replacement for the B12 is usually by injections, and
that's a beautiful color injections. Is it pink or red or something like that?
Yes.
B12.
It's usually. I've never. We normally, it's the primary health care. Usually they give it, but it's worth mentioning that the B12 takes months to be depleted.
So you need to give it more, and the store will slowly build up.
Yes, and if you start treatment, the treatment has to be given lifelong. Yes.
Okay, wonderful. Let's talk about DVT. We got only 5 minutes left, and deep vein thrombosis. How common is it? And let's talk, why is it important with COVID?
Yes. Well, deep venous thrombosis, it is a common scenario, is a common problem. The incidence is about 1 in 1,000.
1 in 1,000.
1 in 1,000 of people
common,
suffer of deep venous thrombosis, and it's very important to mention here that it's clots in the veins, not in the arteries.
Clots in the veins,
And when we talk, it's usually in the deep veins in the legs, the calf, or in the thighs. And
the thighs.
There are certain risk factors which makes the deep venous thrombosis commoner than other illnesses, or commoner in one person from the other. Again, we go to age. This age is another factor, and the other risk factor is having major surgery, which mainly involve the abdomen and
major
pelvis.
Abdominal surgeries, and orthopedic
surgery like hip replacement and knee replacement.
And we give them anyway, as an anesthetists, we always give them blood thinning.
Yes, yes. That's why for patients who have major surgery, as we mentioned earlier, or patients who have general anesthesia lasting more than 30 minutes.
Okay, let's talk here. This is really important for our viewers here. How to prevent this deep vein thrombosis can even happen to our family people who are sitting down at home. They're watching a lot of TV or elderly people. How can they prevent it? What are the remedies we have?
There are, as you know, there is a primary prevention and secondary prevention. The secondary prevention, it means that if somebody got a clot, how to prevent them from having another clot in the future, while primary prevention, how you prevent it from before
Not
it
happening,
happens. Yes. The primary prevention, i.e. before it happens, is generally, it's a general living standards.
Living standard.
You have to adopt to prevent it, like avoiding dehydration and exercises. And
exercises prevent dehydration,
Yes, and also stopping smoking.
Smoking is again, one of the causes,
And of course, the other preventative methods is when the patient comes to the hospital, then the doctors have to,
of course,
do a risk assessment and give them blood thinners, injections or tablets to prevent the risk of clots. That is, we call it primary prevention, so it doesn't happen, of course, if it...
What about with air travel? Especially when you're flying long distances from here to Bangladesh or Sri Lanka, it takes about 10, 12 hours.
Well, this is very debatable issue, and we don't think it is a major trigger factor. And however, some patients, they can suffer of that, and I think these patients, they have probably an underlying factor which didn't show itself yet, either hereditary or an acquired factor. But on its own is not a high risk factor, and if someone presents with thrombosis after long haul flight, the doctor should assess for another hidden factors, such as genetic problems. Or any other chronic disease.
Thank you very much. It's an amazing talk. I think we have covered really important points here. Dr. Abid Abu-Sittar, consultant hematologist and hemato-oncologist. It's a very fruitful program. We talked about leukemia, anemia, and we covered deep in thrombosis. If you have any further questions, you can always write to us on our Health Talk with Dr. Akram YouTube channel, or you could always write to us on our Facebook link, Twitter, Instagram. We'll come back to you with more details. And for all of you for being with us today, thank you very much, and we'll see you in a similar program next week. Until then, look after yourself. Thank you.